So I'm Arnold Postlethwaite from the University of Tennessee Health Science Center and the Memphis VA Hospital. And I'm talking today about the endogenous and marijuana-derived cannabinoids and how they might potentially be considered as further development to treat systemic sclerosis. I tried to communicate to the organizers of the meeting to announce that if you were going to come to this talk and interested in this topic, that you might be able to learn more and gain more from the presentation I make today if you had already watched the YouTube video entitled Weed and Weed 2 by Dr. Sanjay Gupta, who's a neurosurgeon and is a medical reporter and commentator for CNN. So that aired recently, and I thought it was extremely informative, and I would encourage you to, anyone really, because of just general information about where we are with medical marijuana and the status and the problems of this topic, to really pull this up and watch it. And I'll be referring to some of the segments in that as they apply to what we're talking about today. I want to say that I have never smoked marijuana, so I don't have a dog in this fight. I even went to Vietnam as a physician, a battalion surgeon, and was exposed to a lot of particularly enlisted men. I don't remember any officers smoking marijuana, but was quite prominent amongst the enlisted men. I understand it was quite potent marijuana also that was available in Southeast Asia. But I abstained, and so that's just wanted to clear that out of the way. Cannabis sativa is the scientific name for the marijuana plant, and it's probably originated China, and it was first described and reported as a medication around the year 5000. And the Chinese herbal doctors were using this to treat malaria, which is quite prominent in that part of the world, and also to treat constipation and joint pain. I think we're okay. No, it's okay. Yeah. And joint pain and absent-mindedness, I guess maybe Alzheimer's disease, which in the video, Weed and Weed 2, they talk about studies in Israel on Alzheimer's disease with cannabinoids. The Chinese, however, were, as usual, way ahead of our modern medicines with some of the things they were doing. I don't know what female disorders they were treating. It doesn't say any more about that in the particular journal article I was reviewing. And it's interesting in Europe, in the 1800s, England and Western Europe sort of embraced cannabis as a type of medicine. And it was widely used in these countries, while France tend to use it more as a recreational drug. In the early 20th century, the active constituents of cannabis were isolated and their structures were determined and later synthesized in the laboratory. The psychoactive component of cannabis was identified. That's from the resin that's in the flowers and the cannabis resin, and it's called delta-9 tetrahydrocannabinol, which we abbreviate THC. It's one of at least 70 other structurally related, what they call phytocannabinoid compounds within the typical marijuana plant. There are also about a total of 500 other chemicals that are in the marijuana plant. The composition of many are unknown, and so when marijuana is smoked, some of these are taking into the body through the lungs, if you really smoke, I guess, the raw marijuana plant. The THC and other cannabinoid compounds exert their influence and effects by binding to receptors in or on virtually all cells of the body. So what's a receptor? I like to sort of think of a receptor as a baseball catcher's glove, and the baseball would be the cannabinoid. And so the baseball, is thrown to the pitcher, and the catcher catches it. So when the pitcher catches that baseball, that's similar to what happens with the cannabinoid engaging a receptor. So these receptors are on the cells. They're actually inside some cellular components. And they have attached to them signaling pathways that go inside the cell. I'll show you a diagram of this. And this then causes the effect on the cell through this internal signaling pathway. Now, there are two major types of these receptors, the cannabinoid receptor 1 and cannabinoid receptor 2. These are present on virtually all cells of the body. The balance between the numbers of cannabinoid 1 and cannabinoid 2 receptors does vary with the cell type. Most cells in the brain tend to have more of the cannabinoid 1 receptor, while the immune cells express largely cannabinoid 2 receptors. And the ratio of this then is very important and gives some ability for a given cannabinoid to exert a different effect on cells that have a lot of the cannabinoid 1 receptor and a different effect on cells that have a cannabinoid 2 receptor. Now, in the video by Dr. Gupta, he mentioned the fact that the strains of cannabis have been developed that have high amounts of THC, the psychotropic active form, while others have a large portion of cannabidiol, which is non-psychoactive, but also engages the similar receptors, but it has no psychotropic effect in the brain and nervous system. And so it was interesting in this video, there was a farm in Colorado in which a family business, about 5 or so cousins and brothers, have gone together and are actually having different strains of the marijuana plant perpetuated. And they have one particular variety that has virtually, it's like less than 1% of the THC, but it's highly enriched in cannabidiol. So in this particular video, there was a little girl who had almost constant seizures. She was about 3 or 4 years old, as I recall, and the family was just, sort of incapacitated by the constant care that this child required, and she would be seizing throughout the day and throughout the night, as many as 100 or so seizures a day. This is illustrated in this video. It's quite dramatic. The traditional medications that the neurologist prescribed were somewhat effective, but had a lot of side effects. So they got up the idea of trying a cannabinol-enriched plant. And actually, in the video, this family that has this farm in Colorado has named this plant Charlotte's Web. The little girl was named Charlotte. And they gave her, the family, these, the marijuana plant, and showed them how to extract an oil-rich component that would have most of the cannabidiol in it. And then they would give this, I believe, either under the tongue or in the nose, a couple drops every couple of hours. And over a course of several days, the seizures markedly reduced and eventually went away almost completely. So they actually had to move to Colorado because they're in New Jersey and could not obtain permission to get this use of a marijuana plant in New Jersey. So they moved to Colorado and uprooted the family and everything. So that's where they are. Now the neurologist cautioned that we don't know what the long-term effects is going to be of giving this to such a young child. In the video, they talk about also the fact that young brains may be damaged by marijuana in terms of some parts that cells that are developing may be changed, and there is this history in the literature of psychosis being more prevalent in heavy marijuana users, particularly if they start at a young age. So we don't know what the long-term effect of Little Charlotte's going to be, but certainly it is effective in, for the temporary time being of halting the seizures. So I just give that as a caveat because this is an example of how this one industry is trying to develop a type of marijuana plant that doesn't have the psychotropic effects, but have perhaps some of the uses that can be applied medically by the non-psychotropic components. So we talked about the cannabinoid receptor. So this is an example here of the cannabinoid 2 receptor, and it engages THC as well as other cannabinoids. We'll be talking about some animal models in Scleroderma in which this appears to be very important in downregulating fibrosis, the engagement of this in animal models of Scleroderma. But this shows you that the pathways are activated, and these are very complicated, and I don't expect you to learn this. But the end result of these pathways being activated by the cannabinoid 2 receptor is eventually a type of cell death. So these particular cells that are very susceptible to the cannabinoid actually undergo death. And we will dwell on this further because this is one mechanism by which the cannabinoids are able to, for example, kill off various types of tumors. So a variety of tumors that have been looked at in culture undergo this apoptosis or cell death when they're cultured with cannabinoids. And this is an interest that some people have in using this to treat cancer. So the cannabinoid 1 and 2 receptor also has pathways, and also the velinoid receptor is another new class of receptors that are able to induce signaling in response to cannabinoids. And again, the major outcome is this type of cell death up here, this so-called apoptosis, that will eliminate the cells that are activated or that are being activated in an abnormal manner. They tend to be more susceptible to the killing by the cannabinoid. So the body has actually a cannabinoid system called the endocannabinoid system. So we talked about the fact that the cells of our body have cannabinoid receptors, mostly 1 and 2, but also others are being discovered. And, but the body also is able to make the cannabinoid molecules. They're able to really not only make the molecules, they're obviously able to make the receptors for these molecules and all the signaling pathways. They're also able to have the ability to modify some of these cannabinoids into other compounds and even to destroy them and degrade them. So it's a very elegant system of balances of the metabolism of these endocannabinoids within the body. And they obviously serve very important physiologic functions, or they wouldn't have survived through all the different animal systems that we have today, and they're very similar in a lot of the animal systems with some exceptions. So the function, however, of the endocannabinoids is really thought as being a sort of a tonic mechanism to sort of keep things in check. And the major 2 endocannabinoids that have been described, and the earlier ones described was 2-arachidonyl glycerol, or 2-AG, and anandamide, or AEA. The endocannabinoids are very important in responding to a stressful event in which they can be made or synthesized on demand in response to various stresses or inciting events. And then they're rapidly degraded or modified into other molecules that also have their unique properties. So although you may be looking, in a very isolated system at the effect of a cannabinoid, there are metabolites or modifications that may have other effects downstream. So a very complex machinery is in place for handling of these endocannabinoids. But I think that, and I hope after we get through here, you'll see why the endocannabinoid system may be an attractive and appealing potential target for the treatment of systemic sclerosis. Because it influences blood vessels, for example, there are evidence that the endothelial function can be modified and improved. Vascular smooth muscle growth, which is the lining walls in the arteries of a smooth muscle type cell. And when these undergo proliferation or start multiplying, they squeeze down the diameter of the artery. And this causes, for example, pulmonary hypertension or elevated blood pressure like renal crisis that occurs in scleroderma. And the cannabinoids are able to inhibit the growth of these vascular smooth muscle cells. Also, there's able to decrease the vasoconstrictive properties of, for example, coronary arteries or pulmonary arteries, and we'll show you data on that. And then on the immune system, they actually have, in most models that have been looked at of autoimmunity, an ameliorating effect on autoimmunity. They downregulate severity of autoimmune damage in various models. And then lastly, but not least, the fibroblasts can be regulated by the endocannabinoids, and they express cannabinoid 1 and 2 receptors and can be essentially downregulated to not make connective tissue such as collagen. And we'll show evidence of this in some future slides. I just show this to show you the complexity by which the endocannabinoids are synthesized here, 2-AG and anandamide synthesized in this manner. These are what we call fatty acid derivative compounds, so they're fat soluble. This is why the the cannabinoids from the plant have to be given as an oil, like an oil mixture, because they're soluble only in a fatty or oily type medium and not in water, for example. So we'll first look at the blood vessels because the three major components of systems that are involved in systemic sclerosis are the vascular system, the immune system, and the connective tissue fibroblast system. So if you look at the literature on cannabinoids and the heart and blood vessels, there's evidence that they're able to lower blood pressure and slow the heart rate. That's the rate at which the heart beats. And this is primarily through activation of the cannabinoid 1 and 2 receptors. They're also in heart attack models in which they tie off the artery going into the heart that supplies the muscle in rats to the heart. Endocannabinoids treatment of those rats can decrease the size of the damage to the heart. The amount of scar tissue and damage to the muscle is markedly reduced. And this is thought to be done through the cannabinoid 2 receptors because they've developed drugs that will specifically activate the cannabinoid 2 receptor, and that seems to be the receptor that's able to decrease the amount of the heart damage. So activation of the cannabinoid 2 receptor has been looked at by using also synthetic molecules, so-called JWH-133, which has been shown to, activates the cannabinoid 2 receptor. It reduces the inflammatory molecule expression, such as ICAM-1 and VCAM-1, on the endothelium. Now, these are the lining cells of a blood vessel called the endothelium. And you will hear maybe elsewhere in this meeting reference to endothelial damage as being an early problem in scleroderma. And the endothelial cells express a lot of ICAM-1, VCAM-1 in scleroderma patients. And so in the laboratory, you can take isolated coronary arteries from animals and treat them with an agent called tumor necrosis factor alpha or a bacterial extract lipopolysaccharide, and you will upregulate the ICAM-1 and the VCAM-1 on the endothelial cells. And the cannabinoid 2 receptor engaged by this JWH synthetic cannabinoid can block this effect. So the activation of the CB2 receptor also in the coronary arteries of rats was found to be caused by the ability to be dilated through the cannabinoid 2 receptor. And anandamide is able to do this primarily by acting through the cannabinoid 2 receptor. So blocking of the CB1 receptor on the isolated human coronary artery smooth muscle cells, which, as we talked about, are the cells that in the middle part of the artery that when they proliferate decreases the size. So when these isolated human coronary artery smooth muscle cells were treated with a CB1 antagonist, in other words, an agent that will block the CB1 receptor, rimonabant is the name of this compound, it reduced their ability to migrate and to grow in response to exposure to platelet-derived growth factor. Now, of course, this is a contributing factor to atherosclerosis, but also in scleroderma, there's elevation of platelet-derived growth factor released from the platelets as the platelets are undergoing aggregation all the time. And so platelet-derived growth factor will stimulate the growth of these smooth muscle cells. And by blocking the CB1 receptor, you can block the effect of platelet-derived growth factor to have this proliferative effect on the smooth muscle cells. Now, the use of cannabis has been reported in the literature to, however, this is like smoking marijuana in heavy amounts, has been associated with some adverse events on the vasculature. This particular study was done in Strasbourg, France. They had 48 consecutive admissions to their stroke unit in individuals younger than 45 years of age. And they were admitted because they were having a stroke, a so-called ischemic stroke or transient ischemic attack. And in a series of 48 patients, 10 of them had multifocal intracranial artery stenosis. That means many areas of arteries within the brain were narrowed in 10 of these individuals. Of the 11 patients in the series, 11 of the 48 patients who had these multifocal intracranial stenosis, 10 of the 11 patients were using cannabis on a regular basis and suggesting it could be an important contributor to the cause of ischemic stroke. These 10 patients began smoking cannabis on a regular basis several months or years before being admitted to the hospital with this stroke. And during the days just before the stroke, all of these patients were binging on cannabis. And 5 of them also drank unusually large amounts of alcohol. Now, all of the people in this study were also cigarette smokers, so there's this background of cigarette smoke. However, the amazing thing was that these 10 patients had this particular type of multifocal, and in many areas of the arteries were stenosed, and it was only in the patients, 10 of the 11 were cannabis smokers, and only 1 of them was not a cannabis smoker who had this multifocal area. So 6 of the patients, of these 10 patients who were cannabis users, stopped using it after the stroke, and they had a favorable outcome and in many cases reversal of their symptoms without a relapse at 3 and 6 months. And so it was a total reversibility. However, 3 of these patients of the 10 who continued to smoke cannabis, there was no reversibility of the multifocal ischemic stroke. Now, they took MRI and angiographic studies of these patients at baseline during admission and then at 3 and 6 months. And this is an example of one individual who was in this 10 who had had a family history of aneurysms, and so they wanted to make sure that this individual at age 19, before he even started smoking cannabis, they admitted him to the hospital and got this workup to see if he had any aneurysms. And so what we have here is essentially the basilar artery area here in A is really normal. And then he started smoking at age 20, cannabis on a weekly basis. And at age 21, he was one of these 11 people admitted with a left-sided cerebellar syndrome and ischemic symptoms. So they repeated the imaging study, and B shows that there are these areas of narrowing of the blood vessels in a multifocal area. And this C is a three-dimensional shot of this. This shows also the narrowing. And so this individual stopped the smoking, and 3 months later, he was back to normal, just so D looks like A. So this was, I think, pretty convincing that, that the cannabis in this individual was inducing the multifocal stenosis, and it was reversible. So the American College of Cardiology and the American Journal of Cardiology had a review article on the cardiovascular effects, and so they sort of reviewed the literature, and so this shows the cardiovascular, cerebrovascular, and peripheral effects that have been reported, potentially associated with cannabis. So there are reports of increased angina frequency, chest pain indicative of coronary artery disease being made worse after smoking marijuana, and myocardial infarction occurring after smoking, cardiac death, cardiomyopathy, which is an enlargement of the muscles in the heart, and also arrhythmias developing. Then the transient ischemic attacks we talked about, and strokes in the brain. And then the peripheral vasculature, Raynaud's phenomenon has been induced, ischemic ulcers, digital necrosis, and thromboangiitis obliterans. Now, the later three of these are very common in systemic sclerosis patients, right? Raynaud's phenomenon, ischemic ulcers, and digital necrosis. And so this is an example of the toes of an individual who's a cannabis smoker. And you can see the large toe is undergoing gangrene, ischemic gangrene, and there's compromised circulation also to the other toes. So I think superimposing this use of smoking cannabis in Scleroderma patient that already has a potential to have peripheral vascular disease may be somewhat problematic, although we don't have any data to substantiate that, but certainly you would intuitively think that might be a problem. So continuing with the blood vessel story, there is this literature that shows that the endocannabinoids are able to actually dilate human pulmonary artery rings. Now, there are some earlier studies using rabbit pulmonary arteries that showed an opposite effect. So this is important why we need to try to use human tissue whenever we're studying cannabinoid receptors, because there is some difference. And in this particular study, they isolated the coronary arteries from, or not the coronaries, the pulmonary arteries from patients who had lung cancer that had part of the lung resected. They dissected out the pulmonary artery and sort of cut it like little donuts and then put these in culture and experimented with them. So they exposed them to an epinephrine-like compound that caused them to constrict down. And so then they looked at the ability of ANANDAMIDE and VIRODHAMINE, which are endogenous cannabinoids, to relax the arteries. And indeed, both of these were effective in relaxing pre-constricted pulmonary arteries. They thought that this also may involve the generation of prostaglandin PGI2. Now, you heard a talk maybe earlier this morning about prostacyclin and compounds of that nature being useful in pulmonary arterial hypertension. And so the cannabinoids may actually generate some vasodilatory prostaglandins, and that's example in this particular study. Now, this particular study also showed that the endothelium effect was not mediated by the CB1 or CB2 receptor, but the endothelium was necessary to be there. So if they stripped out the endothelium, the lining of the pulmonary artery, and then treat it with the cannabinoids, there was no vasodilatation. But they said that the cannabinoid 1 and 2 receptor is not responsible for this, but it's an additional receptor called the endothelial cannabinoid receptor that was responsible for this dilatation. So what probably happened is the endothelial lining cells, in response to the VIRODHAMINE, probably generated prostaglandin I2, and that caused the dilatation. So it's a somewhat complex scenario, but I think it's very, very interesting and intriguing. So this may have future applicability to pulmonary hypertension if we could develop some VIRODHAMINE-like drugs that could be given to patients with pulmonary hypertension, either with or without systemic sclerosis. Now, the effects on the immune system are really quite complex, and they really have not been studied extremely well. But one sort of can get the big picture that the endocannabinoid system has somewhat of a tonic effect in modulating the immune response and sort of dampening down excessive autoimmunity and excessive inflammation. And so the cannabinoid agonists are able to affect the major cells of the immune system. These are the macrophage, which is at the top here. The macrophage is able to process antigen, and so it encounters an antigen. It can be a component of the body, like an autoimmune disease, and like in scleroderma, like DNA, for example. And then you may make antibodies to the DNA and other components of the nucleus. And this is because the macrophage has processed those antigens and presented them down to the T cells and the B cells. They also, macrophage is able to release a number of mediators. Some of these are very important in scleroderma. For example, interleukin-6 and transforming growth factor beta is produced by activated macrophages, and that is turned off by cannabinoids. The ability of these cells to migrate, the macrophage to migrate and crawl around, is also inhibited, and also to ingest particles of various types is also reduced by the cannabinoids. The mast cell, which in the first 3 years of scleroderma, there's a lot of mast cells infiltrating where the fibrosis is or where it's going to develop. So we see it in the skin, we see it in the gastrointestinal tract, we see it in the lungs, and it's always associated with the presence of fibrosis. And so the mast cells are also inhibited in their ability to release various mediators by the cannabinoids. The natural killer cells also are inhibited, at least in the animal models. There's less evidence that human NK cells, however, are modulated, although it's been demonstrated that heavy marijuana users have low levels of circulating NK cells. But the other effects on the T cells and B cells are really quite dramatic. The proliferation of activated T cells, the expansion of T cells is reduced by the cannabinoids. They also change their, the type of molecules they produce, the so-called cytokines, from a Th1 to a Th2 type to downregulate autoimmunity, and also to upregulate production of transforming growth factor beta, which has immunosuppressive properties, but it also at high levels can also cause fibrosis. But the level at which it modulates immunity is extremely low compared to what is required to turn on production of collagen, for example, in fibroblasts. So the B lymphocytes, which make all the autoantibodies we see in scleroderma, also are sort of shut down by the cannabinoids. Their ability to grow and proliferate is reduced, and to produce antibodies is markedly reduced also. So sort of dwelling on this further, the cellular immune system is the branch of the immune system that is important in fighting tumors, tuberculosis, fungal infections, but also important in autoimmune diseases, including multiple sclerosis, rheumatoid arthritis, and systemic sclerosis. The cells of the cellular immune system also include the macrophages, T lymphocytes, and NK cells, The general effect of cannabinoids, is, as we mentioned in a further slide before this one, was that it downregulates these cells and also changes the cytokines from a Th1 type of inflammatory cytokines that cause inflammation to a Th2 type, which sort of turn off inflammatory and autoimmune reactions. So the NK cells are suppressed in laboratory animals, but modest effects are found in humans, so that may not be a big player in terms of treatment of autoimmune disease in humans with cannabinoids. And the macrophage function, we talked about the inflammatory cytokines being very important, and these are also downregulated. Many of these are important in scleroderma. The B lymphocytes, they make, as we mentioned, the antibodies. Normally these are made to kill organisms and to destroy bacteria and viruses, and cannabinoids are able to decrease the growth of B cells and ability to migrate and decrease the production of autoantibodies. It's interesting that the infections do not appear to be increased in cannabis smokers. So somehow the body is able to not allow this to progress to the point that you don't make immunity to infectious agents. So we don't see a lot of increased infectious diseases in patients who are cannabis smokers. This sort of, it's very complex, but it just sort of reiterates the fact that we have a stress of some sort and the endocannabinoid system is activated, they're synthesized. Also the synthetic molecules that mimic the cannabinoids are also able to shut down T lymphocytes, shut down B lymphocytes, and to cause the Th1 to a Th2 change in the cytokine profile. So generalized suppression of immunity particularly would be important for autoimmunity, and as we see in scleroderma. Now, animal models have been studied to some extent with the cannabinoids. Several have been used. Delta 9 THC, the psychotropic component of cannabis, has been studied, and also delta 8 THC, and also a synthetic dexanabinol. And so the model of multiple sclerosis, which is made in certain strains of mice or rats by immunizing them with an extract of brain or some proteins from the brain, they develop a paralysis that mimics multiple sclerosis, and it's a model that is used to test out drugs to treat multiple sclerosis in the laboratory. So this particular model of multiple sclerosis is markedly improved by these cannabinoid compounds. Type 2 collagen-induced arthritis, which has a warm place in our heart because it was discovered and developed at the University of Tennessee in the mid-70s at the VA hospital in Dr. Andrew Kang's laboratory, and Dr. David Trenum discovered this model, and it has now been used to test all of the current medications we are using in rheumatoid arthritis. And so this particular model is induced by immunizing certain strains of mice with type 2 collagen or certain strains of rats. They develop an arthritis that looks like rheumatoid arthritis. They destroy their joints. And so the cannabidiol, which is the compound we talked about earlier, than Charlotte's Web that the little girl takes, that particular compound shuts down the collagen-induced arthritis model. Autoimmune diabetes in rats, which is induced by feeding them streptozotocin. They develop autoimmune reactions to the pancreas. The immune system attacks the pancreas and destroys it. They develop ability to not make insulin, and they develop diabetes. This particular model also of diabetes is treated and effectively with delta 9 THC. So what about fibrosis? And there are about 4 or 5 articles in the literature on the animal models of scleroderma. Our animal models are not perfect models of scleroderma, but they do have some of the features that we can use. And so I've sort of indicated 3 of the papers here on this particular slide. So in one of these papers, the cannabinoid 1 and 2 receptors were found to be overexpressed in the biopsies of fibroblasts from the skin of patients with diffuse systemic sclerosis. So the biopsies had increased expression of on the fibroblasts of the CB1 and CB2 receptor, while normal biopsies from normal individuals did not have an upregulation of the CB1 and CB2 receptor. So they treated with synthetic cannabinoid receptor agonists, WIN, and I won't go over the numbers, but this particular WIN compound reduced the production of collagen, as well as several fibrogenic cytokines, including transforming growth factor beta, connective tissue growth factor, and IL-6. These all turn on production of collagen and other matrix components that cause thickening of the skin and fibrosis in the lungs. And also the marker for the activated fibroblasts, alpha smooth muscle actin, the so-called myofibroblasts, which is the major culprit in fibrosis in scleroderma. You have in scleroderma patients, a large number of the myofibroblasts are present in the skin and in the lungs. They're just cranking out a lot of collagen, and this particular WIN compound was able to shut down the generation in culture of fibroblasts, keep them from going into the myofibroblast type. And so I thought this was extremely important cell culture data. And they also found that, we talked about apoptosis, or that particular type of cell death being caused by the cannabinoids. So they found that the scleroderma fibroblasts actually died in culture when they treated them with cannabinoids, but normal fibroblasts didn't. So that's an example, too, of an activated abnormal fibroblast undergoing apoptotic death in response to the cannabinoids. So amazing effects on not only the generation of connective tissue matrix, collagen, the generation of the myofibroblast cell, but then actually eliminating those cells. So it'd be great to have a compound that would just kill all of the abnormal fibroblasts in the lung and skin, wouldn't it? So I think that's pretty dramatic. So they then looked at the bleomycin model. That's a model that bleomycin was a compound used to treat testicular cancer and was found to cause fibrosis in the skin and lungs of patients that resembled scleroderma. And so this model was picked up on and developed. So if you repeatedly inject the skin of certain strains of mice with bleomycin every day in a localized area, they develop a thickening of the skin that looks like scleroderma. And some models also, you can put this in the lung, put the bleomycin in the lung, and they develop pulmonary fibrosis that looks somewhat like scleroderma. So in this particular study, this WIN compound, which is a synthetic cannabinoid 1 and 2 agonist, was also able to inhibit the development of the skin fibrosis in the bleomycin skin model. There's another model called hypochlorite mouse model of fibrosis, in which another compound, hypochlorite, is injected under the skin, and they develop skin fibrosis, lung fibrosis. They also develop autoantibodies, anti-DNA topoisomerase 1, or SCL70, which is very common in patients with diffuse systemic sclerosis. And so the B lymphocytes also were inhibited in their growth when treated with the WIN compound in this hypochlorite model. So also the autoimmunity was decreased, the fibrosis, and the number of B cells present. A pretty widespread effect of this particular compound. In another study, which is a little more hard to understand, not being hard to explain this to individuals who are not working in this field, but there's a compound called fatty acid amide hydrolase, which is primarily designed to degrade the cannabinoids. And so this gets rid of excess cannabinoids. So if you knock this particular enzyme out, either by genetic means in a mouse or inhibitors, you actually have an increased numbers of endocannabinoids. And what they did was found that scleroderma patients have low amounts of the FAAH. And when they knocked this out in a mouse, they found that it was highly susceptible to bleomycin skin fibrosis, much more fibrosis in the mouse who didn't have FAAH that was sort of similar to what we have in scleroderma patients, low levels of this, they developed worse fibrosis. And so they found that it was the CB1 receptor that was the culprit here that was causing the increased fibrosis. And they blocked out with this other compound, AM281. And they were able to actually restore the reduced amount of fibrosis in the model in response to cannabinoid treatment. So this is sections of the animal model. And under C, we have all of the controls. And mice, you always inject mice with a vehicle control, which in this case is phosphobuffered saline, essentially saline. And on the right panel of C, there's the hypochlorite, HOCl. And you can see in the upper panel a lot of what we call fibrous tissue, not very much open lung cells at all. And then you see the second one down on the right there under C, JWH133, reduced the amount of fibrosis. You can see the alveoli, the air spaces, and also the WIN compound also had a similar effect to reduce the fibrosis. And that was in this, that was in the skin, I'm sorry, on the left side. The little cells here that you see that have spaces in them are actually fat cells, and that should be what we see normally as a layer of fat under the area of normal fibrosis in the skin. And in scleroderma, in this mouse model, those fat cells go away and are replaced with connective tissue and fibroblasts. The lungs over on the right side had a similar effect. So under D, the panels down the left are all the PBS controls. You see the nice open alveoli. And on the right, upper D is the hypochlorite untreated with a lot of fibrosis and infiltration and a dropping out of the alveoli. And the lower two panels on the right there under D are the JWH and the WIN compounds that reverse this process. The collagen production in the lungs and the skin had a similar downregulatory effect, less collagen production in the mice treated with the JWH and the WIN compounds. So in terms of fibrotic disease in humans, we don't have any real good studies of fibrotic diseases. The literature does show some stuff with cirrhosis due to hepatitis C, but because of time, I just want to summarize. These actually, if you look down at the lower part of this slide, the definitive study was done in a large group in Canada of 690 HIV patients who also had hepatitis C. And they actually found that progression to fibrosis was not associated with cannabis use. However, they found that the ones who had severe fibrosis also tended to smoke a lot of cannabis. And so they were thinking, well, this is what might be what we call reverse causation. So they were getting sick and they felt bad, and so they took smoking more cannabis to feel better. And so that's a problem we have in epidemiology, is which comes, which is due to the chicken or the egg, a cause and effect type thing. And so this is an example possibly of what we call reverse causation. The sicker the patients use more, and then they had more fibrosis. So more studies need to be done. We don't know anything about scleroderma. We don't know anything about pulmonary fibrosis either. And we have a real dearth of the literature on these. The only thing we have are the animal models. So just in summary, scleroderma, as we mentioned, has these three major components: the vasculature, the autoimmunity, the fibrosis, and all of these can be affected by cannabinoids, and we've given examples of how these can be downregulated and improved under certain circumstances. Particularly the CB2 receptor seems to be something you would like to activate selectively in these to downregulate the immunity, the vascular problems, and also the fibrosis. And but when we have this other thing in terms of smoking marijuana may cause the multifocal stenosis in the brain arteries and maybe Raynaud's and thrombosis in the digits. So this is an unknown, okay? And we need more data, and I think we need to try to get the centers that have large databases already on scleroderma patients in terms of their clinical progression over time. If we could just go back and get the cannabis use history in those patients and do a reanalysis, we might be able to come up with something. in terms of, is it having an adverse effect? Is it improving? Do we know? So this is where we are with regards to scleroderma. We really don't know, but I would just have a word of caution that cannabis smoking may not be, because of these potential adverse effects on the peripheral vasculature in the heart and the brain, may not be the thing to do because you've already got some damage in the scleroderma patients. The other problem is because you got these three big players in scleroderma, the immune system, the blood vessels, and the fibrosis, if you, selectively trigger, the CB2 receptors, is that going to have a good effect on all of them or not? So we need more studies to, it may be difficult to design studies, drugs that are going to improve all three. And so we just don't know, okay? And that's where we are. So we need, I think, more research on the use of cannabis. And again, I want to stress, looking at the CNN, Sanjay Gupta's videos on weed and weed 2, to sort of show you where we are politically. And there are barriers to even doing clinical trials now funded by NIH. There's one trial they're trying to do in multiple sclerosis, I believe it is, or seizures at NYU, and they're sort of in maybe the final stages of getting approval, but it's taken forever to get approval because of all the, the hype around cannabis whenever you use that term. But I think there are obviously some, the body's got its own cannabis system, okay, the endocannabinoids, and it does very well, and it's very beneficial, and it can be tweaked, as we've shown some of the experiments for benefit that may be useful in scleroderma, but we obviously need a lot more research in this area. So I thank you.
This was very informative. A lot was over my head, but
I'm sorry.
I mean, no, that's okay. I'm sure you anticipated that, but no, the way you presented it, it definitely hit home and a lot of great points. So for just the common day person who thinks that cannabis can help their situation, what do we do? Do we suggest it to our rheumatologist? What do we do? Like, where do we go if we think we may be able to fit in the positive aspect of this profile? What is the first step in doing that?
Well, it depends on the state you're in, which state you live in. Tennessee has recently approved a restricted use of medical marijuana. I know that
I'm in New Jersey.
In New Jersey, yeah. New Jersey is referred to, actually, they have the governor saying he's done with any other new laws on medical marijuana in his administration. So, and actually this little girl, they lived in New Jersey and had to go to Colorado to get the cannabidiol-enriched marijuana. But under the best circumstance, you have to have, in Colorado, they had to have 2 doctors sign off on this, okay, that the benefit would outweigh the risk. And so, they would depend on the particular state, what's required, and whether you could get a rheumatologist or your primary care doctor. I'm not sure what the law in these states would require, a specialist or whatever, to sign off on it. But this is where we are, unfortunately. And
so I'm from the state of Washington,
okay,
and it is coming out our ears. It seems so easy to get a prescription.
Okay.
My fear is, as a medical practice person, how do you think the FDA might become involved in dosage regulation for therapeutic levels for disease processes?
Well, that's a tough one because, as these videos showed, that's the real problem. The therapeutic window on certainly THC and even cannabidiol, the therapeutic range of which it's effective versus toxicity or no effect is very narrow. Mm-hmm. And so you have maybe one batch extract you've prepared from one group of plants, the same plant, like from Colorado grower, and then the next week, or you make another one, it may have different amounts. And it's a real problem how to quantitate this. And it may never really be done well with the natural extract. It would have to be probably done with a chemically made, drug of some sort. And I really don't know, and this is probably why the FDA is very reluctant to do much in this area, because the dose is going to be a real problem in terms of consistent effect on a cannabis extract, batch after batch.
I would agree. Yeah. Because of my background, I have found it to be a struggle. The people who are selling this under prescriptive authority haven't a clue as to what they're dealing with. They are not educated. They don't have any scientific background.
Right.
I mean, it's no different than going to buy a bottle of whiskey out of Walmart.
Yeah, it's unfortunate. And the dose is going to be very important. I mean, the therapeutic window of which these drugs are active, cannabinoids, is pretty narrow. And you've got to hit that to really see the effect. So.
Okay, thank you.
Yeah, my one question is, are they going to be doing studies that you know of? Not so much like smoking. I'm sort of interested, but I'll never smoke. So, you know, it would only be edibles or that cannabidiol or whatever.
Right, the oil.
You know,
yeah.
and obviously you have to be really circumspect about what you do or what you use, and you got to talk to your doctors. But I didn't know if any of the studies, because you kept talking about smoking. Well, that's never going to happen for me. So
Absolutely.
I wondered, but I am interested in what it might be do to help me. I now take medicine for pain. Well, you know, I'm not sure that maybe this might not be a better option, but I'm not going to jump feet first. So I was curious about what the future might hold in terms of studies in that particular area. You did mention them making it, you know.
Yeah, I think most you know, specialists in this area would not recommend smoking the marijuana, but taking it either you know, by mouth or by oil, nasal, whatever, absorption through the mucosa. And because you have this potential, these 500 different compounds in the plant that are going to get into your lungs. There is a study in Scandinavia of young recruits into the military, in which they have a very regulated health care system, can follow people for decades. And they found that young recruits who had no cigarette smoking but smoked 25 times before they went into the military, their cancer, and they didn't smoke afterwards, cigarettes, they had twice the rate of lung cancer. They didn't say what kind of lung cancer it was in this particular report that I read, but there is this potential for cancer causing by itself by the compound. Yeah, right, by smoking, right. Yeah. Yes, ma'am.
I, like everyone else, and my friend here, have pain all the time. And I was very seriously considering, because I live in California, and every corner in California, every strip center has a marijuana. You just can ask your doc, tell them you have a headache, you can get marijuana. It's very easy here.
Right.
The problem is the edibles. I will not smoke either. I've never smoked,
Right.
and I will not start to smoke now. But the pain of scleroderma, and most people who know the joint pain, muscular pain, and we were just talking, I was just going to say, how do you know if your edibles are good? If one has 10% and one has 50%, and I know you can't eat the whole edible, that much I know. I know you only take a bite of something.
Right. Yeah.
But it's frightening for a person like me to just walk in off the street with a prescription to a corner place here in California and say, I'm hurting, you supposedly know, can I get like 3 cookies?
Right.
What do you do? I mean...
Yeah, the THC content is either not known or certainly variable, you know, from day to day or whatever their supply is. So there really needs to be, you know, I keep going back to the Colorado guys because they're on the right track. They have plants that they sell, you know, that have the known amount of THC and cannabidiol in it. And so the ones that want pain relief that have more THC, the ones for non-pain relief but other medical use, mostly cannabidiol. And that's what we sort of need in some sort of a regulation. Otherwise, it's just a black box. You know, you could get, some of the stuff has very high levels of THC, and you could, you know, just go into psychosis, I guess, with it if you have a lot of it. So some kids, actually, there are reports have taken some of this high THC containing cookies and really had problems. Yeah, it is scary. Yes, it is. Okay, we got time.
I have one question. A friend of mine who's very ill, she doesn't like, I tried it when I was like in high school. I was paranoid. I hated it. But she was telling me she cooks out the THC for like 8 hours so that there's no impairment. Mm-hmm. And what's left is just a little bit of relaxation and sleepiness. And that's what she uses.
Yeah.
She has no impairment. She could drive other than the fact that she's a little sleepy. What do you think about cooking out the THC
Well,
and using
Bradley,
it
do you
for
have
the
any
relaxing
insight into
effects?
that?
If you do that, it turns off the THC into another cannabinoid called cannabinol, which sedates you but doesn't have a psychoactive effect. There's also
safer?
there's another compound called beta-carotene. It's a CB2 selective agonist that's in, I guess, certain preparations of cannabis. I don't really know the details, but if you prepared these edibles a certain way, it may or may not have that in it. And that's actually in pretty high amounts and may be responsible for some beneficial effects, but again, we don't have studies to look at it. Really, the biggest thing would be to advocate for studies and further research, try to get people who have used cannabis that have systemic sclerosis together and get some data to look at and see what the effects of it's been. That might kind of push things forward.